new introductions to make and a very full agenda. I'll just start with my typical announcement at the top that for record-keeping purposes and for ease of taking minutes, if people can just announce themselves at the beginning when we are recording this for note-taking purposes. But if you can announce your name before speaking, it does help us keep track of the conversation. And also, if you're not speaking, it's helpful to stay on mute so that we're not getting a lot of extra background noise. And with those, Melissa, I think you've confirmed a quorum, and we'll take attendance. But before we do, I want to introduce our newest member, Commissioner Manisha Juthani from the Department of Public Health. I'll say a few brief words and allow the commissioner to give some introductory remarks, then we'll go to a full attendance. So Commissioner Juthani is the commissioner of Connecticut's Department of Public Health. She's the first Indian American to serve as a commissioner, as that commissioner in the state of Connecticut. Before joining us, she was a professor of medicine at Yale School of Medicine through September of 2024. She continues to be an adjunct professor of medicine at Yale. She served as director of the Infectious Disease Fellowship Program from 2012 to 2021 and received her BA from the University of Pennsylvania and the MD from my alma mater, Cornell University, at the medical school. So that's great. She's in good company there. And completed her medical residency at New York Presbyterian Hospital, Weill Cornell campus. I'm just thrilled to have her join us. I know as she continues in her role as commissioner, she prioritizes emerging infectious diseases and is committed to revitalizing public health by refocusing efforts on opioid crisis, lead abatement, gun violence, mental health, and climate and maternal health, including healthy drinking water. And I just think she's the right person to sort of refocus our energy after the pandemic on the public health pieces that we all need to pay extra attention to and the impacts that could be disproportionate on vulnerable populations. And she brings important lens to that work. I also want to say, as a matter of personal privilege, that when Commissioner Juthani first joined state service, it was in her first week that we threw her right before into action, and she nobly led legislative approval and ratification of multiple $1 million in federal grant allocation plans for both maternal health and good population and public health initiatives. And it was then fitting that the second day on the board, when she was officially appointed, she joined me before the Appropriations and Public Health Committee to advocate and lobby for approval of our Tobacco and Health Trust Fund allocation plan of $13+ million. So she is definitely one who rolls up her sleeves and is ready to do the work with us. And I'm thrilled that she's joined the Tobacco Board. Commissioner Juthani, do you want to say a few words?
Thank you so much for that very kind introduction, Claudio. It's always been a pleasure to work with you, and I really look forward to joining this board. Many of you have worked with Dr. Jody Terranova, who was my appointee and our appointee on behalf of DPH before this. As Claudio mentioned, I used to say in my 3 buckets of priorities for the Department of Public Health, one being emerging issues, emerging preparedness related to infectious diseases or other preparedness related issues. The second being our regulatory hat, whether it be in healthcare quality and safety or in drinking water or food protection. But the third I used to say was revitalizing public health. Now I really call it preserving and protecting foundational public health that we know has worked for decades. And one of those is tobacco cessation and prevention. We know that when we look back, for those interested, in April of 1999, the MMWR published by the CDC issued some of the top 10 achievements of the 20th century. And advances around tobacco were one of those 10. And so, in the long list of things that Claudio mentioned that I'm interested in focusing on in terms of preserving and protecting public health and revitalizing it. But I think we're in a stance right now where we're really trying to prevent backslide on things where we've made great progress. And tobacco is one of them. And so I look forward to being a part of this board and working with this team. And thank you very much for that introduction.
Excellent. And with that, Melissa, I will ask you to take the roll and note that Parisa is joining us again. I know she was on a little bit of an extended leave for good family reasons, and great to have Parisa back joining us today. But I'll let you call the roll.
Thank you. Chair Claudio Gualteri,
Here.
Robert Boris,
Here.
Parisa Charmchi Goodwin,
Here.
Aisha Clark. Okay. Ann Foley,
I'm here.
Samuel Hahn,
Here.
Tony Harp, Cindy Harrison,
Here.
Stephen Hernandez,
I'm here, thank you.
Suchitra Krishan Soren,
Here.
Matthew Jasinski,
Here.
Commissioner Manisha Jutani,
Here.
Christopher Moran,
Here.
Michael Rell,
Here.
Tricia Orozco, Andrew Salner.
Here.
Okay, that concludes attendance.
And that confirms that we do have a quorum. So with that, I'll move to item number 2. Everyone should have received in advance of today's meeting the October 23 meeting minutes. I'd ask for a motion to adopt such minutes from October 2024.
So
Do I have
moved.
such motion? Dr. Salner, thank you. The motion is moved. Do I have a second?
Second.
Second, Chris Moran, thank you. Any discussion, need to amend, or clerical edits to the meeting minutes as drafted? Seeing none, I will ask that we take a motion to approve the minutes. All those in favor, we could do this by a voice vote. All those in favor of approving the minutes from October 23, 2024, please signal by saying aye. Aye.
Aye.
Any opposed? Abstentions?
I'll abstain, Claudia,
Claudia,
since I
I'll-
wasn't there.
Great. We'll reflect Commissioner Jutani as an abstaining. And Parisa,
And
was
this
that
is
you I
Parisa,
heard
same
also
for me.
abstaining?
Yes, because I wasn't there. Thank you, Claudia.
Excellent. Thank you. The motion carries.
And I'll abstain
All road.
Tony Harb.
Sorry.
Because I just got, I just wanted to note that I abstained. I just got
Okay.
it.
Excellent. Thank you. Welcome. So the meeting minutes carry as adopted with 3 in abstaining. Next, I just want to outline the goals of today's meeting. We have a very robust agenda, as I mentioned at the top. And today's meeting is really focused on what we've heard from the tobacco trustees, Tobacco and Health Trust Fund trustees, all wanting to get a better sense of the projects that we are funding, the outcomes, how we're delivering impact with the allocation plans. And with that in mind, and specifically a lot of the attention around the quit line, which our board has put significant resources behind, we want to spend much of today's meeting receiving an update from DPH on the outcomes of the 2023 RFP process and next steps for the allocation of the 2024 funds that have been approved by the legislature. We will also have an in-depth presentation from the new Quitline vendor, which is National Jewish Health. There's some new and enhanced use capacities that they're bringing to bear in that intervention. So I thought it would be helpful for all of us to get a presentation from them and entertain any questions you have. I also think this is an opportunity for us to transmit the documents that they provide to us to our legislative friends who have had a keen interest in learning more about the Quitline and how we're continuing to revitalize that important service. We will, however, begin with a presentation that we held over from the October meeting, which is an update from our DEMIS colleague Sarju Shah will be here to talk about the work that DEMIS is doing in investing annual Juul settlement dollars and per statute reporting to the board on the funding that materialized through that settlement agreement. And with that, I will go ahead and turn it over to Sarju and tee it up for you, Sarju, give you a second to get organized. Pursuant to Public Act 2392, DEMIS is required annually, beginning in September of 2024, to submit to our board a report of the disbursements of Juul funding to the Regional Behavioral Health Action Organizations, the RBHAOs. I think it's important because we've always talked about our board being a conduit for connecting all the work that's happening across the cessation space and mental health and addiction. And so this is one way we're staying true to the board, having a bird's eye view of all the different investments that are happening so we could best link those and make sure when we're developing the next allocation plan, we're augmenting and not supplanting the work of other state agencies or other programmatic initiatives. And so with that, we're going to include a progress of the disbursement, where the RBHAOs are in their planning process, and how to target and spend the funding. I think in advance of today's meeting, you all received the submission, the formal submission from DEMIS. Today is meant to illuminate further on that and give us a verbal presentation on that report. So with that, I will introduce Sarju Shah, Division Director of Prevention and Health Promotion at DEMIS. Thank you, Sarju. Take it away.
Hi, good morning, everyone. And thank you so much for that wonderful introduction. I feel like you can do the whole presentation for me. So this is just a very quick, high-level update of our annual report from 2024, and just to walk through it a little bit. Again, and thank you so much for showing about the collaboration that we have between DEMIS and the trust, with this group, as well as DPH. But the mission for DEMIS itself and the prevention service especially is to promote the overall health and wellness of individuals and communities by preventing and delaying substance use and fostering mental health. So our approach really includes a comprehensive system of strategies designed to reduce risk factors and then also enhance protective factors that contribute to healthy behaviors and lifestyles. DEMIS provides prevention health promotion services across the lifespan. So we really look at not just the youth, but across from 0 to 99 in essence. So just as a little bit of background, and again, we did talk, you did mention about the Public Act 2392, which requires that the Juul settlement dollars be dispersed to the 5 regional behavioral health action organizations. Now, these specifically for youth prevention work related to nicotine and nicotine synthetic products around Juul, and for those who are under the age of 21. So the RBHOs, as they are lovingly called within DEMIS itself, we are operated as DEMIS partners to carry out prevention initiatives around substance use and misuse. And they also work around problem gambling, as well as promoting mental health services across the state. And these nonprofits actually build the capacity for local communities and serve about the 169 towns by building capacity and infrastructure, identifying gaps, and coordinating and leveraging resources. The map here represents the 5 RBHOs and the communities that they serve. From the 169 towns that we have in Connecticut, the RBHOs support over 150 local prevention councils and also support the towns that don't have a local prevention council. So we really get grassroots activities happening at that level. And since May, we have developed a 16-month contract that was executed with the 5 RBHOs, and we've dispersed thus far $1.5 million by September 30, 2025. So with that, just a quick update of what we do. So the Strategic Prevention Framework, this is a model that developed by SAMHSA to help communities address substance misuse and related behavioral health problems. We see, as seen in the graph above, or where you can see it, the 5 steps really focus on assessing local prevention needs based on data, then build capacity, readiness to address these prevention needs, and then focus on planning, implementation, and evaluation. Now, this is really designed to be a dynamic and iterative process and is guided by cultural competence and sustainability. So all of the RBHOs have gone through this process thus far. and really focus on assessing the needs, looking at the data, building the capacity at the internal and external levels. And then right now we're working on the strategic plan. Now, since May, this has been that systemic community-based approach. And then they've been focusing on that end of it. With that said, this slide over here just kind of showcases and walks through the timeline of the funding. So we're able to get funding out the door by May 2024. They've been focusing on building the capacity, doing the needs assessment. Right now, by the end of this month, we will have a finalized strategic plan as well as an evaluation plan of how the next set of funding will be entertained and worked out. Oh, I'm sorry, did I go backwards? So I'm sorry, this was the slide that I was mentioning. And then just high level, during the needs assessment, the following themes really emerge, and it's really detailed in the report itself. But we looked at the fact that geography and density of retailers selling vape products in urban core and urban periphery is higher. We also noted that for treatment, vaping is used as a coping skill for mental health and anxiety. The youth perception of vaping is less risky and less harmful. So that's a big area that we're going to be focusing on. And schools are in need of assistance in promoting restorative practices. And we're looking, and this is based off of looking at some of the student reports, the 2022-2023 report on student discipline in Connecticut public schools. So we have been utilizing the data that's out there, both from the Department of Education, Department of Public Health, and other agencies to really look at what this looks like. And so that's just some of those high level points. With that, under the capacity building, what we've noticed is that RBOs are working to enhance and strengthen the partnerships in the communities. They're providing training to community members, including parents, schools, and youth, among others. And then on the risks of vaping, as well as looking at utilizing the strategic prevention model for that end of it. We're also working to educate primary care networks on vaping resources, as well as providing training to school personnel around evidence-based and evidence-informed curriculums, as well as alternative cessation programming, and other nicotine and tobacco cessation resources. Also, the regional coordinators have become trained as tobacco cessation specialists to gain additional knowledge of tobacco addiction, withdrawal, and effects of treatment methods. And this will really help to tailor the prevention strategies needed to support adolescents across the regions. In the past month, some of the things that what we are seeing through the strategic planning piece is that the RBOHs have conducted environmental scan of school policies. They've begun outreaching to educate staff in the benefits of restorative practices. We're also looking at another area really focused on local zoning and policy review related to vaping retailer density within their communities. All of the RBHs have focused on retailer education and supporting the work that we're doing over at DEMIS with our tobacco prevention and enforcement program. We're providing free materials, we're increasing awareness of the required online retailer training, and we're kind of we're really working together on that end of it. And they're also forming regional vaping work groups to address vaping in their respective communities. And finally, they are reaching out to healthcare providers with materials and risk and cessation resources. The resources provided really brazen the work of what the Department of Public Health does, the cessation programs, increasing awareness of the quit line. We really work to ensure that we're working with our sister agencies and utilizing the programs that are already out there and the resources that are there. And finally, the next steps is really the evaluation plan, developing a sustainability plan, and also this continued capacity building and implementation. With that said, this is my contact information. If you have any questions, you're welcome to feel free to reach out to me. And I am going to stop sharing. Are there any questions?
Thank you, Sarju. That's a very succinct and helpful presentation. And I know we do have a question. Suchitra, you get the first one.
Thanks. Good morning, everyone. Thank you, Sarju. That was very comprehensive. And I really liked the report you sent out earlier, too. It was really nice to read that. So thank you for that. So, I'm raising this question just because we've just gone through a process of coming up with a plan for dispensing all the tobacco dollars from the Tobacco Health Trust Fund, and we are going through this process of dispensing it. And a lot of the programs that we'll be hearing about soon are focused on e-cigarette prevention and e-cigarette cessation. And I was wondering, what is the link between the work that the RBHOs are doing and what these programs will provide? Because it seems like your goals are kind of similar, in terms of what you're doing a needs assessment and then providing prevention methods. And, how is there a plan? I guess it's a large question for both our group as well as for you to link all this, so we're not doubling the work.
Oh, no, and that's the great thing. And I understand that the Department of Public Health went through an RFP process, which is a little bit different as well. But the great thing about the Department of Public Health and DMHS is we work hand in hand in many of these activities. So our plan is to work with DPH and those contracted vendors to really work with them and support them in the work that we're doing. Because again, the way that I look at public health is sometimes it takes 6 times for people to hear the same message from different ways of really making it and connecting with them. And the great thing about this is, looking at the presentation very quickly, I see that, we work hand in hand with like Southern Connecticut. We work hand in hand with many of the other agencies. So this will be a great way for us to work together, build resources, build capacity, and work together to support these to our communities.
That's great to hear. I have one more question, Claudia, if that's okay. This is regarding, when we are developing these programs, let's just keep in mind that what kids are vaping nowadays goes beyond nicotine. There's a lot of marijuana vaping going on too, so we shouldn't lose sight of that. So just enough for us to pay attention to.
And that's a really great point. And what we do within DMHS and within the prevention is we have the cannabis prevention programming. So we have the Be in the Know campaign. We are working with the RBHOs as well of doing those polysubstance pieces because we do know what's out there in the communities. And we're also embedding that into our tobacco retailer program. So DMHS itself, what we do is we are mandated through the SINAR amendment to go out and do to help support enforcement. So identifying retailers that are selling to youth or do undercover pies, of ensuring that retailers are knowing what the laws are in Connecticut. They are educated. They are around the youth access laws. We are doing the retailer education pieces of it. We work with a lot of the retailers in that sense. And what we're also doing as part of that, not only I can talk about the enforcement of it quite a bit, but one of the big things about that is, we do the enforcement, we do the undercover buys, but we're really focusing on that education end of it. And in conjunction with our RBHOs to ensuring that, it's not, what are the new trends? What are the new type of vape products that are out there? Is there cannabis out there? And we have done a lot of that partnership education also with local police departments and making sure that they know what the laws are. So we do build that in. But it's a great point, and I'm so glad that you brought that up. Thank you. All right, if there's any additional questions, please feel free to email, call, or send them to Melissa and Claudio, and I will definitely answer and respond. Thank you.
That's great. And I suspect we'll have some follow-up questions as we get closer to potentially another allocation plan, and making sure to take your feedback and learnings through your RBHOs and bring that into our planning process. So thank you for that. And we'll move on to our next agenda item then. Our next agenda item is to discuss the updates of the FY 2023 and FY 2024 RFP process. And for that, I'd like to turn it over to Commissioner Jutani, who can also introduce her staff who've been hard at work. And I also recognize many of you on the board were part of the process of evaluating and helping to award several of these projects that came through the RFP process. So big thanks to the board as well for your shared commitment in that regard. Commissioner Jutani?
Yeah, thank you so much, Claudio. So yes, I do want to thank each of the members from this group that volunteered to participate in that process, which was very important, and want to just take a moment to recognize Julie Vigil, who is our branch chief overseeing this work, and Allison Sullivan, who works directly with a number of the contractors who are going to be working on, the proposals that you all reviewed and that I will share further now. Claudio or Melissa, is one of you going to share the slides, or did you want me to do that? You can do it.
Up
That'd
to
be
you,
great.
Commissioner. I'm happy to do that. I have them if you would like.
Okay, that would be great, Melissa.
Yep.
Sorry, I'll have to keep
Sure.
saying next slide, but that would be fine. Yeah.
That's fine. Let me get that up for you and shared. Okay.
So, I certainly will be available to answer questions on this as we go through this presentation. And if there are things that I can't answer between Julie and Allison, we should be able to answer any other potential questions that you may have. So we can proceed forward from here. Just to give you a sense of what we're going to be talking about, you can go to the next slide if possible.
I'm trying. I
Oh,
apologize.
yeah, no problem.
You're frozen on my screen. Just a moment. Okay, now we should be good. Oh, and yes, there you are.
I don't see the slides, Melissa. Is it sharing
You're
on
not-
your end?
It shows it. I apologize. Let me try again. Let me just transfer. I apologize.
Melissa, if you would like me to
Okay,
share
there you
them.
go.
Okay.
No, it's okay. I'm sorry. My screen's totally froze, but we should be all set now.
Okay, yes, I think we can all see it now. So great. Thank you. Just to recap what we're going to discuss today. The first, just to review what the basic components were, then the status of the RFP for FY23, the Mass Reach Health Communications update, and then sort of the infrastructure update. Again, the parts that support DPH in terms of us being able to do this work and where we stand in terms of FY24 RFP. So next slide. We can go further. So just as a reminder of the 5 basic components, the first component being that of state and community interventions. This is really, municipalities, community-based organizations, other groups that are doing work on the ground, getting messaging out. That is separate and apart from the Mass Reach Health Communications. And as a reminder, that Mass Reach and Health Communications was a separate RFP. So that was one RFP. And then there was a second RFP that was for components 1, 3, 4, and 5. Number 3 being cessation interventions. Number 4 being surveillance and evaluation. That's really the data piece of this. And then the 5th, infrastructure, admin, and management. That's really us being able to actually execute on this work at DPH. So we can go to the next slide. And one more. So as a reminder, again, in terms of how this group allocated the $12 million, we can see that for component 1, 35% of the 12 million allocation went to that, 12% to that single RFP Mass Reach Health Communication intervention, 40% to cessation interventions, 9% to that data piece, the surveillance and evaluation, and then 4% to admin. And you can see how that translates into exact dollar amounts in the subsequent columns that you can see. And with specifically at that time, 500 designated to maintain the quit line. That was an initial allocation, and there's an additional total between FY 23 and 24 that ultimately gets up to, I believe, 3 million total for the quit line. And we'll be hearing about them a little bit later. Next slide. So in terms of how this actually translates into what happened with the RFP process. So as I mentioned, for components 1, 3, and 4, there was an RFP. I misspoke before, component 5 being the admin piece, that wasn't involved in the RFP because that's really just the DPH part. So components 1, 3, and 4 were in one RFP. And what you can see is that for component 1, we had 7 different proposals that were received, and of those 3 were funded, and the 3 funded organizations are the Catch Global Foundation, the City of Bridgeport, and then Southern Connecticut State University. I'm going to go down to then component number 3, which so for cessation only, we received 2 proposals, but nobody was funded for cessation only. And what happened was that there were applicants, 6 applicants that applied for components 1 and 3. And out of those 6 applicants, 3 were funded. So it's not that nobody was funded to do cessation work. It's just that they were funded to do cessation work, but they were also a community and state organization. This included the American Lung Association, Farmington Valley Health District, and the Wheeler Clinic. And then lastly, for the surveillance and evaluation piece, this is component number 4. There were 2 organizations that submitted proposals. 1 was funded, and this is iPro. And this is, again, is going to be the group that's going to be able to help evaluate how all the programs are doing overall. I see that there's a question.
Thanks so much, Commissioner. And I wanted to start out by complimenting your staff. I was involved in the RFP process, and they did a fantastic job. And you may have mentioned this, but I just wondering why we didn't do competitive bidding for the Mass Reach Health Communication.
I'm coming
funding.
to that next. We did.
Oh, okay. Okay.
We did. And once I get through, it's just because they were 2 separate RFPs. I'm going through this RFP first, and then I'll talk about the mass communications one.
Okay, great. Thank you.
Yeah, no problem. So what I was just trying to highlight was that because the mass communications was a separate RFP, I'll get to that in a minute, but I'll just, sort of go a little bit more through the scope of work. We can go to the next slide of these that were identified as recipients from the first RFP. Cindy, you have a question?
I do. So I'm just trying to understand here. I think that we wanted to encompass the state of Connecticut, and it's just clarification, I think, on my part, because I was not involved in the RFP process. So we've given approximately $750,000 to the city of Bridgeport, and then some to the Farmington Valley Health District. Is that going to be strictly for those communities, or do they also have some outreach into, say, the broader community or into the state?
So I think some of that is clarified through the scope of work that is identified, and also what's in the RFP. If we can go to the next slide, Melissa. Yep. I just want to at least explain, what we've got here first. Also to recognize that we have applicants who apply to do, let's say, direct community-based work. We only have the applicants that we receive, right, in terms of a given area.
And maybe that's the answer. So
right, and I would say, so there are 2 things. One is we only, whoever applicants we have is who we can review, number 1. Number 2, in the FY24 RFP that we are going to be putting out for the 14+ million, one of the things that we're going to be saying is we want to have different groups, right, and different areas. So for the second allocation, I think some of what you're talking about could also be addressed. And then third, there are these multiple components. So there are certain outreach efforts that are going to happen across the state everywhere, just based on what the nature of the intervention is. While some of them, there may be very specific targeted work that's happening in specific areas. So I will just go through this and then turn it over to my staff to see if they have anything else to say different than what I've said. But I want to just highlight a little bit about at least what the groups that we are going to fund, what type of work they're going to do. So is that a good start, and we can go from there?
Absolutely. Thank you. Listen, I totally agree with you. We want these funds out there. We want them working. And if it's a function of who applied, then so be it. Good for them.
Right. Right. Okay. Well, so let me start with, Catch Global Foundation. The goal of this group is going to build capacity in school districts to deliver sustainable youth vaping prevention education for students and parents in Naugatuck Valley and South Central Connecticut planning region. So that encompasses 15 towns, right? So when you ask about, let's say, the city of Bridgeport, at least Catch Global Foundation, there's 15 towns that they are going to be servicing, particularly South Central, Connecticut planning region, Naugatuck Valley. So that's one area of the state. They're going to develop and empower youth advocates to take action in support of community tobacco-free policies, and then enhance district tobacco-free policies and referral pathways to ensure students and families receive information about and have access to prevention, education, and cessation support services. One of the things I will also point out here is that we're only awarding them $750,000 out of what they proposed, which was $1.5 million. And part of the reason for that is because some of the areas that they were proposing to cover, I would have to go back to the team to figure out which it was. But as an example, let's say that they proposed to cover Bridgeport and we're awarding the city of Bridgeport directly, then we didn't want to have two contractors serving the same area. So that is why they got awarded a smaller amount, because we're asking them to serve these areas of the state that we know that other contractors are not going to be servicing. So that is also to your question and point, which is that Catch is only getting 750, not the 1.5 that they asked for, because we're asking them to work on these areas of the state that they said they could work in. The second is the city of Bridgeport. They're getting their full funding that they proposed, the $773 plus $1,000. Again, similar types of work, engaging, mobilizing, and training youth advocates to encourage implementation of policies, preventing tobacco use initiation, promoting the use of cessation services, and creating smoke and vape-free areas across the city. So this is a very targeted intervention right in the city of Bridgeport, right? Like creating smoke and vape-free areas in the city. I think that's part of the reason why the city of Bridgeport was awarded, because they were looking at very targeted interventions right in that city. And then Southern Connecticut State University is getting their fully funded proposal as well. Again, looking at creating environmental change in the school system. So K through 12, peer-to-peer training, policy support, training community partners and schools and health professionals, and really creating a tobacco-free college technical assistance initiatives and community outreach programs. Any questions on those three? Okay, we can go to the next slide. So this is now looking at those components 1 and 3 together. Okay, so this is, again, cessation with that messaging piece, which is cessation being component number 3. So these are the 4 groups that were awarded for components 1 and 3 together. So similar to what I said about, catchment area and where you're going to work, what kind of work you're going to do, you can see the American Lung Association applied and proposed for over 8 million, but they are only being awarded 4.9, close to 5 million, again, in order to target their work in areas that other contractors are not going to be duplicating work. So to make sure that we fund things specifically related to what we want them to do versus what other groups are going to be doing. So here, this is going to be a centralized state effort in some of the following objectives, raising awareness about the importance of adopting tobacco-free environments, reducing youth access to tobacco products in the retail environment, communicating dangers of youth tobacco use and secondhand smoke, promoting quitting and providing direct cessation services to priority populations, promoting health systems change to integrate tobacco cessation into routine care, and expanding insurance coverage and awareness of cessation benefits. So the American Lung Association is going to be looking broadly at these sort of centralized statewide efforts that we're asking them to do. Farmington Valley Health District is getting their fully funded amount of $600,000, which is to advance and maintain a comprehensive approach to anti-initiation and cessation of tobacco. And this is, again, in their specific area. So this is, specifically around cannabis among the youth population in 10 district towns. So this represents 110,000 residents. So for those who are unfamiliar with our health department districts in the state of Connecticut, we've got 59 health departments and/or districts districts can be multiple different municipalities that are within that area. If you have a big city, for example, like the city of Bridgeport, they're their own health department. In this situation, the Farmington Valley Health District makes up 10 different towns. So it's not just the town of Farmington, as an example. It's 10 towns that they are going to be working in to be able to do this work. And so that health district is going to be doing that work. Then we have the Wheeler Clinic, which is being awarded its fully funded amount of almost 1.1 million. And they are focusing on tobacco prevention and cessation statewide in LGBTQ plus and Black adult communities while addressing secondhand smoke and aerosol exposure, coalition building, and the like. And then lastly, this is for component number 4, as I said, the data evaluation surveillance piece. So that is the 4th component. It is this group iPro, who is being awarded a little over $1 million, and they're going to be assessing the effectiveness of these interventions. So all these groups that we look at, they're going to be collecting the data, doing surveillance, producing results that we can then share back with you to be able to have a comprehensive and impactful evaluation of our state and local efforts. So all this money that we have allocated and that will be going into these specific interventions, we'll be able to see the outcomes of that and actually see how the programs are doing. Next slide. Okay, so to the question that was asked before about component number 2 on the 5 mass reach health communication. So again, this is the component number 2, which went through a separate process. And so the process that we went through here is that there are 5 Department of Administrative Services, so the State Department DAS, that has contracted media vendors, and they were all approached to request proposals. We asked all 5 for tobacco control program media advertising by strategies. Out of the 5, only 2 proposals were received, and out of the 2 proposals that were submitted, the one that was awarded was the O'Donnell Company, and they are receiving the $1.3875 million to do that work. The statement of work in this regard follows that they're going to help formulate research to identify promising messages and concepts and to pre-test some campaign and marketing materials that meet those specific goals, develop and recommend a strategy for a media buy, purchase advertising space and boost social media messaging, assist in the creation of additional campaigns, assist contractors with the development and implementation of local media promotion, so related to the contractors who are doing this very work, and then at the end, gathering metrics to evaluate the effectiveness of those campaigns. Any questions about the media RFP? Okay, so then lastly, to go to component number 5, which is all related to the admin within the Department of Public Health. This is infrastructure and admin. So funds that have been spent to date for FY23, we've spent $525,000. Some of that went to actually just paying for 2 days of solicitation of RFP in the way that we're required, which is in 3 newspapers. Catering for some of the RFP panel review meetings to be able to help support all of you and others who participated in this process. And then salary and fringe and indirect expenses that will be charged starting this Friday, January 24th, for a health program associate position. That position was posted. There were 132 applicants. 10 people were selected for interviews. An offer was made and accepted on December 31st. And the person who is starting in that role is Amanda Fata. She will be introduced to this board in the upcoming meeting in April, and she is going to be helping with all of the contracting, programmatic work, all of the work that's going to be involved with working with each of the contractors that we've talked about here to be able to follow up and make sure that this work is actually executed on as we've outlined for you. Next slide. So, I just want to comment that all these contracts are in development. The statement of work are in development. So, honestly, we don't have the contracts in place to actually give you deliverables or data or outcomes out of these contractors that have been chosen. But I think we've come a very long way in being able to finally soon, hopefully, be able to start seeing some output from those contracts getting signed, the work actually being done, and then being able to see how it actually is playing out in the community. But while that's going on, we're moving on to the next fiscal year as well, which is fiscal year 24. And the board recommended disbursement as outlined here. So just as a reminder for all of you in terms of how you all approved to move forward with this funding. So components 1, 2, 4, and 5 were all slightly reduced so that component number 3, cessation interventions, could be increased. So this was increased to 48%. And so that had been 40%. And it was increased to 48% by the board so that, more money could go towards cessation interventions. So now what is going to be going forward is a new RFP for this $14+ million. So next slide. So again, just as a refresher in terms of this, with that 14 million, what we are looking at is that based on our discussions with OPM and our understanding where we need to go from here, for component 2, the Mass Reach Health Communications, we do not need to submit another RFP for that. So at this point, we're going to be extending contracts, including FY24, for the Mass Reach Health Communications. Now, if for some reason we want to change that at some point, we do have the ability to do that. But as of now, this is the plan for that. Secondly, for the existing 2 million that has been allocated to National Jewish Health, we again do not have to do another RFP for that. So as you can see, out of that 14+ million, 2 million is going to be going towards that. And then again, for component number 4, the surveillance and evaluation piece, IPRO will also in FY24 be awarded those funds to be able to do that piece. So the RFP process for FY24 is really going to be for component number 1, the state and community-based organizations, and component number 3 for cessation. And this time, what we're going to be saying is that we do not want applications submitted where they address 1 and 3. We want 1 and we want 3. Also, just to reiterate that for components 3 and 4, even though we do not have to go through another RFP process, their receipt of this funding will be contingent on performance and evaluation of their services. So it is not an automatic. They will have to perform and they will have to meet the deliverables as outlined in the contract in order to be eligible for the next bout of funding. Question?
Thanks again, Commissioner. And I'm sure you addressed this, but I must have just missed this component for the National Jewish Health. Can you say again why that has spiked out from the overall cessation funding and why they're the vendor for that?
So I was not part of this board before, but I do know from my team, and they can comment with you a little bit more, but we needed to make sure the quitline funding was going to continue. And that quitline funding through National Jewish Health was partly in FY23, which was 1 million, and then 2 million from FY24. So this board had already approved as a carve out for that funding to be able to continue so that that cessation quitline funding was not interrupted and stopped by this process. So Claudio, I saw you came off mute. Did you want to add to that?
You did perfectly, Commissioner. I will just say this was a topic of deliberation and discussion of the board, and we sort of took what the advocates were saying when we went for the first round of allocation. And one of the key points was, in addition to doing all this great stuff and getting the resources out there, consistency matters. And one of the areas where we felt we had a body of evidence that we put money in and it worked and it had good outcomes was in the quitline. Over the history of the Tobacco and Health Trust Fund Board, we revisited the 2017 retrospective, and they specifically called out the successful interventions that happened through the quitline, knowing that we were going to get a new vendor and adding new enhanced capacities to that program, and how important it was that if we're doing all the marketing around quitline, that someone's there to pick up and execute and actually help deliver those services was so important. So we did do a multiple year contract. My understanding is that the 2 million in combination with the previous amount allocated in the 23 plan will allow for 5 years of continuous iQuitline service at the enhanced capacity that we've contracted. So it was an important thing that the board did signal. Thank you.
Thank you. And I do recall all of that, and I'm a strong proponent of Quitline. I guess I just never realized that National Jewish Health was the vendor for Quitline. For some reason, I thought that Quitline was the name of the vendor. So thank you for that.
And it's a new one, Ann, so you're
Yes.
not mistaken. It just switched over.
Oh, okay. All right. Thank you.
Another question? I
Representative
see.
Harrison.
So thank you for all that information. And I think you answered my original question. And if I understand it correctly, we're looking to expand and hopefully get the right RFP in response. We can only obviously award what we get as a response, but to look to expand to other parts of the state who may not have either responded or been awarded. Am I correct?
Yes, so one of the things that we do want to do, and can you just go and see if, I don't believe there's any other slide, but I think this is the end of the presentation, but if you can just confirm. Yes, so this is what part of what I was saying before, which is that we're looking for proposals to be focused on components 1 or 3, that we are going to be clarifying Q&As that were submitted the last time and update data that we published. So, you know, that we have 2 big surveys that we do sponsored by the CDC, the Behavioral Risk Factors Surveillance Survey and the Youth Risk Behavioral Survey. These 2 points of data do help us have eyes on tobacco use, cannabis use, cessation, all of these types of things. So that is also what we're going to update. But to your question right now is the last bullet on this slide, which is that we are going to be recommending projects to fill gaps in service areas that were not included in the FY23 selected projects. And that's part of what we're going to be asking for in this next RFP.
Perfect. We just want to make sure that we can capture as much of the state as we can. This is
Absolutely.
You know, so good. Thank you.
Absolutely. That is our every goal as well. And also just a few additional clarifications. We want to make sure the next time that all review panelists review all applications and score each of them. That is traditionally how we do things at DPH, and we're going to make sure we do that. And also we, are always looking for volunteers for those who want to participate in the next RFP round. So if any of you would like to volunteer, please contact Allison Sullivan so that we can have that. And if there's anything else the board would like to see in this next RFP, this is the time. I think as you've highlighted, Representative, we can we have the same goal as you. We want to make sure that we're covering as much of the state as possible, and so we're going to be trying to solicit applications from as many places as we can, as many health departments, whoever is interested and willing to do this. So, I think that is the last slide that I see. We can maybe stop sharing the slides just so we can see questions as they come up a little bit easier. I believe, Dr. Salner, you had a question?
Commissioner, thanks so much for the excellent presentation. And just a question about timelines. And Claudio, please excuse me if I'm jumping the gun on this question. Can you give us a sense about when you think the contracting will be ready and that these current RFP contractors can start their work? And when, that might, I guess, start the clock ticking.
Yeah.
And when the next RFP contracts would then potentially come into effect, because I don't know how long in advance that will be.
Yeah, it's a good question. And I will just say that, contracts is something we've worked on very hard at DPH to streamline that process and get contracts through so we can get money out the door to actually get the work started. For these particular contracts, I'm going to ask Julie and Allison if they have any specific feedback as to timelines for when we think these contracts might, or like what, I don't want to overpromise, but kind of when we think we might be able to get them done, what timeline do we have right now, and when we think the work may be able to start. Allison
Commissioner,
or
I
Julie?
can, yes, I can take a stab
Okay.
at that.
Thank you.
So currently the awardees were notified the first week of January that what their awards were. And I know that the team is going through the process of finalizing the statements of work and how they fit to the RFP process. And I think the plan is to get these up with contracts within the next couple of weeks, and if Allison can shake her head yes or no with that plan, and I might need her to jump in. And once we start that process with our legal department, we're hoping, as the commissioner stated, that we will have this streamlined. I've already had a few conversations with our legal team as to tools that we can use to help get the process moved forward. So
I just wanted, before I turn it over to Allison, I will say that state contracting in state agencies is not easy, and it requires several steps. So even though we will be working over this on the next several weeks, I do not anticipate, I would anticipate several months before contracts get signed, and then the work starts after that. So then in terms of, I think 6 months from now is a good check-in for where we'll be at, like how much has the work actually taken off. I think it would be reasonable to hold us accountable for 6 months from now. Where do things stand, Commissioner? Like I think that is a reasonable accountability thing to ask me, I would say. And so, I don't know, Allison, if you have anything else to say beyond that.
Sure, I will say that my team has been working hard to get the processes started, but we are so looking forward to having Amanda start on Friday, who will really take the lead on once she's onboarded and ready and familiar with all of the contracts that we are funding, with all of the various outlines and draft contract language that has already been done by staff. We're hoping to get that in the queue, and I think that, a 6-month check-in would be a good goal.
Yeah, and I'll just add, I think some of this is outside of the agencies. There are processes put in place for good reason, right? I mean, we want to make sure, I know from the advocate perspective, we want to get the money out there as quickly as possible. We want to get the money out there as quickly as possible with the appropriate financial controls and protecting the taxpayer dollars as well. So sometimes that process can be frustrating from the outside looking in, but we have to also remember, I think, that there's a deliberative process where the AG will look at the contracting. We want to make sure that people have a contract in place and the terms are clear and enforceable before work begins. So I do urge everyone's patience. I know DPH is working with all deliberate speed, but also making sure that the impact is protected, because that's what we ultimately all care about when we look back on this work. I'll also just say, by way of summation here, because I know we are running over and we want to get to the quit line, is how grateful I am for DPH for doing the administrative component. I think a lot of times we put money out there and we want every single dollar to go to impacting community, and sometimes we shortchange the infrastructure that's needed to make sure that it's deliberate and that the funding can actually be impactful and meaningful to communities. And it's quite a testament to DPH and how much they've absorbed within their existing capacity to keep the administrative costs to 3-4% of this. So I do appreciate Commissioner Giuttani. I know that's a heavy lift, and given the expertise you're bringing to bear for this, I appreciate the management and infrastructure that you've lent to this project.
Thank you, Claudia, for that. Sorry, go ahead.
No, go ahead.
I was just going to say, I'm just vocalizing what the team is doing. The team really, it does take a team, and it requires a lot of work with contract specialists, attorneys, program staff. Having this new health program associate is going to be a big lift and help to the existing staff, because is getting each of these contracts through, before I entered state government, I would not have understood really why they are so important. But having seen situations where contracts were breached, where things were not delivered the way they were supposed to be, and when you go back to that contract language and actually have that, that's why we go through this process. And it's the taxpayer dollar at the end of the day that we are trying to protect. And as Claudio said, all these safeguards have been put in place for a reason. So it is onerous, it is time consuming, but at the other end of it, when things don't go right, you are very grateful that you had that contract in place to be able to do what you need to do. So let me turn it to Dr. Christian, I believe, Christian Sarin.
Yes, hello. I also want to add my congratulations. I worked with your team on the reviews, and I was very impressed with how organized they were and how well they pulled all that together. Since you asked for feedback on what the next RFP should focus on, one of the things we had discussed during the review process was that while the proposals we have funded and what we've gotten in the first round were very comprehensive and covered a large area, there were not many that actually focused on minority communities or LGBT communities. And that, I think, would be great if you could write the RFP or guide people in terms of that need. I think we will get more proposals that are focused on those communities. So just a suggestion.
Yeah, thank you very much for that feedback. I mean, I think one of the ways that we sometimes can also do that and put that into the scoring system as well is to say that we will preferentially be looking at applications that specifically address these types of interventions in the outlined communities that you highlighted, and then can sort of have the scoring system as such to be able to reflect that. That those that maybe address those specific need or issues are addressed. So, if anybody else comes up with other feedback as you think this over and think about our presentation, feel free to let us know. We are in that development process right now. I thank you for that feedback. We will take that into consideration in terms of how the final RFP is put together. And I know, Claudio, that we're running late and you have another presentation. So I'll turn it back to you unless there are any other questions for me.
That's great. Thank you, Commissioner Giuttani. Yes, and we do have, our next item is equally important, and I know that we're eager to get an update from the quit line. So I will, without further ado, turn it over to the staff from the National Jewish Health to present on the quit line.
Okay, I think that's me. My name's Dave Woodruff. I actually am with National Jewish Health here in Denver, Colorado. I will say I'm originally from Massachusetts, so I'm going to turn on my fast talking mode. So, because I know we're running low. So let me go ahead and share my screen. Bear with me a moment.
As long as you're a Giants fan, we're okay.
We'll keep talking later. So. And let me know, can you see my first screen, my first slide? Cool. All right. So we'll go through this. Hopefully it sounds like a couple people might not be familiar with us yet. So I'll do a quick little intro on National Jewish, but we are very happy, very proud to be the quit line vendor for Connecticut since July. So just not too long, a little over 6 months now. So we'll kind of start working through this, and there we go. So National Jewish Health, we're out here in Denver, Colorado. Founded in 1899, it was at the height of the tuberculosis crisis. So we've had a history of pulmonology, and right now the hospital itself, which is obviously down closer to the downtown area here in Denver, but they are a research hospital for pulmonology and allergies. So they're very focused on that. We are a nonprofit academic medical research center. So really that means that every dollar that we earn, whether through the quit line or anywhere else, is going right back into research. So we are constantly researching these things. Quite frankly, I always kind of like to kind of point out our original motto as a nonprofit was none may enter who can pay, and none can pay who enter. The hospital itself prided itself that it would accept everybody and anybody who had that history of tuberculosis at the time, or any pulmonology type of situation. So it wasn't until I think sometime in the 1960s where we actually started taking money. We certainly will take money today, but for a long time we really didn't. So so we're very proud of that. And really the quit line itself, we are the quit line vendor. So we do kind of operate under QuitLogix, is our kind of trademark name. We are a division of National Jewish, and our program itself started to be developed in 2002. So a little over 20 years now, 23-ish, wherever we are. We are currently, I believe, actually not just the largest nonprofit, but the largest provider of telephone-based tobacco cessation services in the United States. So we're very proud of that. We keep growing our family, which is great. And we do, a lot of lessons learned. We kind of leverage, or we try to have the states leverage upon each other, kind of build that community so we can really kind of focus on the next piece, which is evidence-based. Nothing that we do is just throwing the spaghetti on the wall. Everything we do is evidence-based. So we look for the research, we look for the clinical side to say, is this the right approach? Is this the right way to do things? And maybe part of that is because we are seeing the highest, some of the higher quit rates of around 37%. I have a slide a little bit further on that kind of shows you a little bit more of a correlation between some of the factors involved in quit rates, but that is kind of typically our average right around there, that 37% with our state line quit vendors. So we are very excited about that. And of course, we're not quite at the McDonald numbers, but we've been able to treat 2.5 million people with their quit attempts in the last 20 plus years. So again, I talk about evidence-based. This is some of that evidence research that we kind of leverage on, that kind of helps us to guide us to what we need. Two main pieces or bodies of work back in 2006, the Cochrane report really did show that the dependency or the quit, having that successful quit rate with kind of geared back to the telephone, the telephony cessation services. But also some of these tables came from a 2008 clinical update, where it showed that the more coaching sessions, the more sessions that an individual had, and of course that particular table is much more talking about overall clinical cessation work along with telephone, but the more cessation sessions that the individual had, the better their chances of quitting. As you can see from the side there, it goes from 12.4 with 0 to 1 up to 24.7% when they have 8 or more. Obviously, there's a sweet spot there. We can't all keep having more sessions, but we do encourage more and more sessions for the individual. And then additional, you can kind of see that abstinence rate when it comes to no help, meaning no help or just self-help, or they start talking to somebody through a quit line service. And this is specifically the quit line counseling, goes from 8.5 to the 12.7. And then finally, whether or not they are doing it without medication or with medication, meaning NRT, the nicotine replacement therapy, which again, we'll talk a little bit more, but we also see that jump in the quit rates when it came through. And all of this was based upon that research studies, which are cited into the slides. Going on, I'll just kind of point out, these are our current quit line partners. So we are pretty widespread across the states. We actually currently are working with 25 different states, 3 of which are either a standalone just youth program, meaning the My Life, My Quit, but Maine also, the state of Maine just recently also signed on to AICTP, which is our American Indian Commercial Tobacco Program. It's something we do offer in all of our states if it's something that they desire to have, but Maine actually has that as a standalone unit within the state, which is where we really look at the sacred use of tobacco versus the commercial tobacco for the American Indian population. But again, across the states, we try to partner, we try to meet everybody where they are, both in a budget and culturally. So a little different in each one of the states. It's always kind of fun and exciting. Here, I just kind of highlighted some of the quit rates that we are seeing, and this is the most current. This is within really the last year through some of our outcomes reporting. And we kind of see that direct correlation. Obviously, we have the same base service, and we'll get into talking about a little bit about that in a second here. But you can see some of our states with the higher quit rates are also offering quite a bit of NRT. So we do kind of leverage that NRT when it comes to the quit rates. And you can see this, and I didn't want to use names, get the names of it out of it, but 41% for state number 1, and they're offering 10 weeks, while state number 2 is at 40.7 with 12 weeks. But then at the other end of the spectrum, we have the states 9 and 10 around that 28 mark, and they're offering 8 and then 4 weeks of NRT. So we do see that correlation between offering the more NRT, the nicotine replacement therapy, coupled with the coaching cessation services to kind of promote that quit rate and keep them on the right track. And again, very encouraging here is that, our benchmark, which is from NAC, the North American Quit Line Consortium, is at 30%. So we do see that higher quit rate or above the benchmark pretty much across the vast majority of our states. Our staff itself here at National Jewish consists of 90+ staff members. Most of that obviously within the coaching staff. Our coaches themselves, we kind of split them into two little groups. That we have our CCRs, our agent who actually handles the initial call, and again we'll go into the overall process in a second. But they're handling that initial call when it comes to the intake process. And then there's the coaches, and the coaches are receiving a very large amount of training. That's 150+ hours of training. As we get into the specialty programs, the specialty protocols, they're receiving additional trainings from there. And then of course they're always receiving the annual training to keep them refreshed. We always have a clinical and a medical director on staff, or at least in a role or a functional role. Currently, we are in the process, I'll just be transparent, we are in the process of hiring a new clinical director. Our old clinical director deserted us and went to become the president and CEO of NAC. So we're very excited for him in that new endeavor, but that's Dr. Iliola. Moved on not too long ago. So we are in the process of finding a new clinical director. But since we leverage the hospital for quite a few things, we're able to kind of leverage Dr. Tinkelman within the hospital as our current clinical director. So, so we have that going on here. The program itself, and I'm just taking my time here. Good. Obviously, we're primarily within the phone service, but we're seeing more and more folks who are wanting just web services. So we're looking for different ways to kind of leverage that web service. I think as we kind of move and evolve as a society, we're seeing more and more shift from the phone. In fact, we don't even use our phones as phones anymore in most cases, to web and to give them that self-help through the website. So we are constantly building up that suite of digital services for them. Personalized educational material, which again, we'll talk a little more about in a second here, but we do provide each participant going through the program, whether they're web or their phone, to receive more personalized education materials that will help them in their journey through their quit attempt. And of course, depending on state budgets and so forth, we do offer that nicotine replacement therapy for all eligible participants, again, defined by the state on what that looks like. Our phone coaching is available 7 days a week. We are closed a couple days for holidays, Christmas, Thanksgiving, notably. But our online resources are always open 24/7, obviously. So anybody who needs that can certainly go to the website and get additional information. Coaches, our in-staff coaches speak English and Spanish, while we also have access to the language line, who offers 200+ languages. So if somebody speaks Portuguese and calls in, we can certainly get a translator on the phone to speak that language as well. And then we do a transfer, I believe is a pretty standard item, over the Asian Quit Line, which does cater to the Mandarin, Cantonese, Vietnamese, and Korean languages. So, and I think that's out of UC Berkeley. Going on. So this is our overall process flow. So the intake, we start with that. It is fairly extensive. We do try to limit it as much as possible, but we are following the MDS question sets set forth by both NAC and CDC. And that gives us that leverage to be able to tailor their journey to what they're going through. And we'll talk about some of those protocols in a moment too. So we start with that. Then we certainly we get them enrolled. That's obviously our primary focus, get them enrolled in the program, which is really starting with that first coaching call. So we are looking to really, from the time that they call us or the time we contact them, and again, we'll review that. But by the time we have that initial contact with them, we were really looking to get them into that coaching session. So we do that within the first call whenever possible. So if the person is calling in and they're talking to that individual agent on the intake, and they are not a coach, then they transfer it over to a coach. And if it is a coach, then they go ahead and continue the conversation. In that first coaching call, they are talking about NRT and the NRT usage. If they are eligible, we'll go ahead and get that ordered for them, and we'll discuss the usage. We do both monotherapy, meaning a single therapy units, patch, gum, or lozenge, or we'll do a combination therapy, which is a combo therapy, meaning a patch plus a gum or lozenge. And so the coach is going to talk about that. They're going to explain kind of how that works, what the usage is, you know, give them the instruction that they need. So when they do receive it in the mail, because it is mailed out to them, that they'll be ready to go ahead and get started. And then kind of put in here the outcomes. So what we do, and again, we'll talk about it. We are not currently doing that for Connecticut, but we do have a program. We can have the outcomes evaluations reports coming through. That is initiated during the intake when we're asking for that permission that you know, during the intake process, no matter what, you know, whether or not we're doing it or not, we are looking for that permission from the participant to be able to contact them within the 7 months. So that gives them the outcomes, whether or not, you know, and that's how we gauge the quit rates, the satisfaction rates, and so forth. So our program eligibility for the state of Connecticut, obviously you have to be a Connecticut resident. So that's primarily the biggest issue. You have to be at least 13 years of age or older. If somebody does call in and they're below that age, we would kind of do a timeout. We wouldn't turn them away completely. I would actually then reach out to you to make the final decision on how to handle that. Typically, we see that parental consent is typically required at that point, but it is a case-by-case basis. And unfortunately, we have run across that in the past. NRT, of course, is only available through our program for residents who are 18 or older. We do not supply NRT to anybody under the age of 18. Program overview, really, you know, they can get into us a few different ways. They can call the 1-800-QUIT-NOW or 855-DAY-LA-FOIA. They can enroll online, so they can go to the website, they can enroll, we can then make those outbound phone calls to them. They can be referred to us by a provider, a medical provider, through a fax, web, or e-referral. And of course, we have a specialized phone and website for the My Life, My Quit program, which is the youth sensation program that tailors to the kids between the 13 years old and to 17. So that's a little bit of a different community. You know, they certainly have their own language some days. The program, the base program itself, is a 5-call program. It's obviously the intake call itself, which is standalone to that. And then we do up to 5 coaching calls. So that the program complete is when they hit the 5. If they have a slip, if they have or need additional support, they are certainly more than welcome to call us. But the program itself is the 5 calls. And again, as I mentioned before, we can do that in English and or Spanish, or if they have a preferred language, we can certainly get that translator on the phone. Again, the follow-up, I'll just kind of review this really quick. With our phone program, we will attempt to contact all the participants within 3 times within 5 days, at varying times of the day. So if somebody is going through the web, they say, hey, give me a call, we will then attempt to make contact with them up to 3 times before we, not to say we give up, they are still obviously in our system if they ever decide to call us, but we're not going to continue to berate them for the appointment. Similarly, if they order through NRT on the website, we're going to make those attempts to them with the 7 to 10 days following that same criteria, 3 times within those 5 days. And if they miss a coaching call itself, so we do schedule all calls after the initial call. And if they miss that for any reason, that we do make 3 more attempts to try to reach that individual to continue in their journey. You know, I'm not going to go through too much because it looks like we're running low. We'll talk about our digital suite of services. We do have a mobile-friendly website that's available, very easily toggled between English and Spanish. There's a lot of interactive tools that are certainly available through there. Motivational text and email messaging system, they can sign up for that. It is triggered on various things, and it is tailored, especially if they've already gone through the intake process, it will be tailored to the individual. So for instance, we have a PPP, pregnancy postpartum program that Connecticut is currently using. If somebody is going through that program, they'll receive specific text messages that's tailored towards that journey. And then we do have a 2-way chat available online. It is not for the adult program part of the coaching sensation service, but if they need that additional support or if they're just having an urgent, they can certainly chat in with a coach and they can kind of hopefully get them through that hump in the time. The education materials, as I mentioned, does go out. It is tailored to the individual based upon the answers we received during the intake process. So obviously everybody receives the My Quit Journey workbook, so that kind of gets them started so they can work through it. But then the rest of the packet is a little more tailored to what they're going through. You know, if they're using vape, if they're using smokeless tobacco, cigarettes, if they're currently pregnant or going through postpartum, if they have a behavioral health issue, if they're part of youth. So there's a whole cadre of different types of educational pieces that we'll kind of package in. So we try to meet them wherever they are in their journey. And those are printed in both English and in Spanish for the individual. NRT, the nicotine replacement therapy, again, as we saw earlier in some of our slides, that does increase the participant's chance of successful quitting. We do ship that out to the participant. It is a brand name, so it is not generic. It doesn't look exactly what you're going to go get in CVS, but it is definitely a Nicoterm product. So that they're going to get that directly to their home, and they are eligible for the amount of NRT allocated by the state once per year. So while they can continue to have a quick journey with us through coaching, NRT is limited to the once per year. Obviously, there's some costs associated with that. But the NRT options that we currently have in place here, they are able to receive up to 6 weeks of patch, gum, or lozenge. That is broken into 2 different ways. We can do patch, gum, or lozenge as an individual monotherapy for them, if that's what they desire. But we also highly encourage that combo therapy. And the combo therapy is where they're using a patch and potentially also having a gum or lozenge for those quick hits. So when you're having that urge, when you're having that, that moment, you have to get right through it. They can, and the coaches certainly talk through this with them, but they can pop that gum, they can put in the lozenge, and it gets them through the urge a little bit easier. And then what we typically see in this type of a program is the second shipment would be patches. They typically don't use up all the gum or lozenge, which in that short period of time, so then they can kind of maintain that throughout. And once, unfortunately, if we have somebody who is unable to receive any more through us, we are highly encouraging them to reach out to their local insurance, to their private insurance or government insurance to see what NRT benefits they might have through them too. So having a little bit more in their hands. A couple of the programs that we are currently handling in Connecticut is, I mentioned, the pregnancy postpartum program. This is a specialty protocol that we have specifically for folks who are pregnant or expecting. And it consists of 9 coaching calls total. So it is a little bit beyond what our normal coaching protocol are. This includes 5 during the pregnancy period, and then an additional 4 in the postpartum period to try to continue to maintain them throughout the first year of the life of the baby. The difference here in the program is, while in our standard program, it is a little more general as far as the staff that's involved. In this particular program, it's a dedicated female coach. So if somebody is currently pregnant and they call in and they enroll in this program, they are going to be assigned the same coach, the same female coach for each of their scheduled appointments. If they call in due to an urge, or if they, kind of outside that scheduled window, they might not speak to the same person, but we do try to schedule them for to have that conversation with the same person every time. We, again, as I mentioned before, the text messaging, the emails that they might receive through the program are a little more tailored towards them. And we actually recently incentivized this, and we can have a whole conversation about incentivization for the different quit attempts. We do see that helps to improve their chances of going to that next call. So for the pregnancy postpartum, we do have a $20 gift card that's issued to the person for the completion of coaches calls 1 through 5, and then a $30 completion for calls 6 through 9. And really, it's whether the pregnancy or the postpartum. So we are usually, we usually see these numbers. I believe the program's been around for about 5 years, so we'll probably be doing another evaluation of the program soon. About 44% of the evaluator or the participants actually made a quit attempt during the program, and 68% had completed 3+ more calls during the pregnancy and 3+ more calls during postpartum and had remained quit for up to 6 months follow-up. So that was really encouraging to sustain that usage or sustain that quit rate beyond the normal program. My Life, My Quit is another program that we're currently offering within the state, a little bit different than our adult program, though obviously this is tailored a little more towards the youth. The program itself, we developed just about 5 years ago as well, and it is with youth involvement. It was not a standalone. It wasn't me sitting in a room, or a bunch of 50-year-olds like me sitting in a room trying to figure out what would be nice to the youth. We went right to the youth. We said, well, what's going on? What do you want to see? How do you want to see this? We are in the process of kind of revamping this because the youth have grown up that we worked with, so we need to talk to more people. So this is a little bit of a different program. The fact that it does leverage more of technology. They do have a dedicated short code, so they can enroll via dedicated short code enrollment, which is 36072. That does give them to the motivational texting, but also kind of encourages them to enroll in actual coaching services. They can call directly in, or they can go to the mylifemyquit.com website and enroll into the services as that way as well. Difference here is that while in our standard adult programs, coaching sensation service or coaching sensation is really considered a phone call. It is considered an interaction with a coach. In the My Life, My Quit program, we expanded that so that it is not just talking on a phone, since I have teenagers and they don't seem to ever want to talk on the phone. It's all about texting and chatting. And so that's also been expanded over to this program as well. So a coaching session, and we do have the ages trained, or the coaches trained specifically for this program. It involves also texting and coaching as well. That also kind of counts, quote unquote, towards one of those sensation or completion of the program. And again,
I hate to cut in because this is such good information, and I'm grateful that you've sent the slide deck and we can recirculate it for everyone in advance. But I did want to, in the interest of time, at least allow for some questions because we're hitting up on time.
Oh, sure.
Do you want to just take like 30 seconds to sum up, and we'll see if there's any questions?
Yeah, I can do that. Let's just see. I can throw this out there too, just to kind of see what our utilization numbers are since we've started the service in Connecticut. But I'm going to jump to the next one and then maybe kind of spark a couple questions here. So this is that utilization more in a graph form, so you can see month by month how we're doing. But yeah, are there any questions of what I've covered so far? Maybe then we have time to talk about some of our upcoming or potentially available programs for you.
Great, thank you so much. Does the membership have any questions? Yes, Suchitra.
Sorry, I seem to be full of questions today.
I love it.
I have a question about how do you handle folks who call in saying that they want to use vapes or e-cigarettes to quit smoking? Do you consider that in your education at all?
Yeah, vaping is not a approved method by the FDA for sensation services, so we highly discourage that. And in fact, the sensation service that we do provide actually includes it's tobacco, it's nicotine service. So we will treat a vapor the same as a cigarette smoker. It is still a sensation, or they can still be eligible to go through the sensation service, and it is not what we would encourage them to use as a replacement.
Thank you.
Representative Harrison has her question up. Dave, can I also ask before we go to Rep. Harrison, there's a number of people in the chat have expressed to me an interest in continuing this conversation. If we send you written questions, is it possible to get some responses and to sort of round out the presentation that way?
Absolutely, yeah.
Okay, great. So if we don't get to your question today because we ran out of time, please send questions to me and Melissa, and we'll make sure to triage those and get those full answers out to the group. Thank you. Representative Harrison.
I'm going to start with saying thank you very, very much. This is like extremely informative. And you can send a written question. It's a comment. I understand the youth are, more interested in apps, and, we all use our phones, and didn't I get a pop-up ad about, quit smoking and an app? And so it's more, are we thinking about that for the future? As a way to go.
No, thank you. It's a great question, great point. Yes, the youth, they don't want to look you in the eye anymore, it seems. They always want to be on their phones. So the My Life, My Quit program, we are currently in the works of revitalizing. We, again, as I mentioned, we just don't do something because it's the most popular thing to do. We need to have that evidence base. We need to have that research done. So one thing we are working on currently is rehaul of the program itself. From there, we will be looking at an app. So how do we tie in, not just to provide an app to give information, but how do we tie the app back to the initial program that the individual is going through? So that is obviously, you know, something we're currently working on. There are some HIPAA, you know, thoughts around that, and you know, of course, we need to make sure that the PHI is certainly protected. But that is something that is on the horizon that we are looking at, and I will have much more conversations with Allison as we move forward with that. But it is not far away. I'll just say that.
Thank you for the comment.
Yeah.
All right, so with that, thank you again for the presentation. We'll circulate some questions and gather those up, Dave. And I suspect the group will want to have you back maybe in a few months after we get through this process, if you're amenable to it. So, and we'll also share, by way of follow-up, your slide deck to some of the legislators. The Appropriations Committee and Public Health Committee in particular wanted some of the granular data, which you've provided in an excellent presentation. So we'll make sure that they're informed of your good work too.
Sounds
Thank
good.
you.
And I'd love to come back whenever you'll have me. So
excellent. Thank you. So just moving along in the agenda and recognizing we have very little time, I'll briefly say that next up for us as we look towards the April meeting agenda, we'll continue the standing agenda item around DPH budget and project updates with vendor presentations as appropriate. And in April, we'll also include behavioral health risk assessment surveillance system data that was collected by DPH, and they'll give us a presentation on that. So that moves us then to item number 8, which is an opportunity for public comment. I did see joining us today at least a few members of the public, including some of the consumer groups that we work closely with. So I wanted to pause in case Ruth or Bright, who was on earlier, he may have had to drop, or other stakeholders would like opportunity to make comment. Seeing none, we will move to the last item, which is a motion to adjourn today's meeting. Do I have such a motion?
So moved.
Moved to do I have a second?
Second.
Second by Michael. Thank you. All those in favor, signal by saying aye. Aye.
Hi.
Aye.
Aye.
So ordered. We're adjourned. Have a great day, everyone. Thank you.